Okay, thank you, Mandy. This may be a recorded version that you're listening to, and we would still like it to be as interactive as possible, so there may be some spots during the presentation where you could pause and talk about some of the topics that come up instead of chatting, or think about the responses you might give to the polling questions rather than actually responding as if it were a live program. There are notes and other information available through MPro in relation to this topic and this session. So feel free to explore those through your MPro point of contact, or their website. Some of the information that we collected feedback-wise from participants from last time when we asked which behavioral model communication style would you pick to work on, here's what folks told us. That they would want to start acting in more of a servant role to the patients, negotiating more than dictating, so getting away from that parent or that teacher mode and getting more into a sort of a colleague role with the patients where you're actually negotiating with them. Assessing motivation instead of trying to motivate the patient. A lot of times as practitioners we want to say the right thing, give the right information, download information to motivate the patient, when a lot of times it's sort of taking a step back and having the patient assess their own motivation and figuring out what barriers or misconceptions might be in place that prevents their motivation from being higher. Some of you talked about understanding and accepting the patient's current stage, not labeling the patient, and making sure that you are in an information exchange mode, again, instead of that information download mode. The types of patients that came to mind as where you might start applying this would be in areas of weight loss, when that might be a goal that the patient was setting, or around adherence. Could be medication adherence, could be adherence with other treatment regimens that you're recommending. Some of the founding or the basic building blocks of motivational interviewing behavior change. One part of that is assessing the patient's readiness to change. A common model that's used to do that, or to put that into context, is the Prochaska model, also called stages of change or trans-theoretical model. And if you think about it, anytime that you're working with your patients to set a goal, they're going to be in one of these 5 stages. They'll be in pre-contemplation, contemplation, preparation, action, or maintenance. You notice the arrows that are showing up here, basically indicating that at any given point in time a patient could be moving forward in this ladder. They could at some point take a step back. Once somebody gets into the maintenance phase, they might relapse all the way back to the pre-contemplation phase. We're going to go into more detail on each of these, but keep in mind that sometimes it's better to think about not trying to convince the patient to change behavior, but helping them to move along this stage or this continuum. And that then the patient might sort of take over and change their own behaviors as you help them move forward on this program. So the first polling question that we'd like to put out there for everyone would be, are you currently in your practice assessing stage of change or readiness to change with any of your patients that you're trying to help set self-management goals with? So you might want to just take a moment and ask yourself that. Are you doing that right now? If not, would there be barriers for you starting to do that? It does not have to be specifically using those categories we just talked about, although again, that's a pretty well-developed and commonly used approach. But the reason that it's important to do this in some regard is to be able to know what your next step with that patient would be. So a pre-contemplative patient, the next steps might look much different than somebody who's in a preparation phase and ready to move forward with taking action. Let's start out with the pre-contemplation stage. This is somebody who is maybe that resistant patient, the type of patient that often comes up, we've tried everything, they don't want to do anything, what else are we going to do? That really difficult difficult situation where you're not sure what to do next. The characteristics of this type of patient is that they're not even considering change. They might be in a denial mode, is how that might be recognized sometimes, or they've tried to change in the past and failed so many times that now they're really leery about going down that road again. They don't want to meet with those same barriers and fail again, and they think it might be pointless. Your strategies, the specific things you can do is continue to educate. Let them know the risks of the behavior and the benefits of change. Highlight some of those positive things that they would see right away, early on, if they were to commit to some sort of change plan or goal setting. Contemplation stage would be somebody who is ambivalent. In other words, they have mixed feelings. They're not sure if it's important enough to change, but they're not quite sure it's something that it's safe for them to continue to do. The person, even if they're not verbalizing it to you, they are weighing internally the benefits and the pros and the cons. So the strategy, again, specifically what you could do, continue to highlight pros and cons. Also try and get the patient to talk more about, are there any barriers? Tell me more about what you think about this change we're asking you to make. That's how you would reveal misconceptions or barriers. The barrier might be something you may never have thought of. It may be a work-related schedule issue where they just don't have time to go out, and they think an exercise program means joining a club or joining some weight loss center. And you might just have to kind of identify that barrier and work around it, come up with a creative solution. Anything that can tip the scales in favor of the patient, thinking that the change, the benefits of the change outweigh the sacrifices they have to make, would be moved in the right direction. So this would be a point to maybe pause or stop and think, what are some of the pre-contemplative patients in our practice? And the example we give is a smoker who refuses to even talk about quitting. They came in for some other reason. You ask about their smoking, you might get pushback, resistance, maybe even a little bit of sense of frustration right away. A contemplative patient, what type of contemplative patients do you have in your patient? How do you recognize those folks? Example might be somebody with high cholesterol, maybe high blood pressure, something that hasn't been an urgent matter for that patient in their mind. They know it's not something that is going to be good long term, but it's not important enough yet, hasn't risen high enough on their radar screen to make any changes. Now, maybe something's changed in their life, that window of opportunity for them and for you to readdress it. Maybe their friend has had a heart attack, and now the patient is saying, are there any easy diets that he can try? That's an opportunity to step in and highlight the positive changes that patient might be able to experience if they wish to start on an exercise program or a new diet. So think about pre-contemplative and contemplative patients. What types do you have in your office that you see common? The preparation stage is somebody who's ready to start on small experiments or small changes, and they may have even done it already in their own day-to-day life. So that's important for them to at least start to verbalize that with you. What you can do for them specifically is to make sure they have realistic goals. So if the change that they're experimenting with is losing 20 pounds, that might be, really frustrating because they might get that first 5 pounds and then they might go into a phase where the weight isn't coming off as quickly. Frustration sets in and they take a step backwards. So it's an opportunity for you to break down their changes into small, achievable, realistic goals. Let them experience the success that will breed more confidence with them and sort of build on itself over time, and definitely provide sort of reinforcement to the patient. The action stage, this is a person who is already diving into that action, that plan. They've set a goal. They've put into place some steps that they have started or are ready or are beginning to start. Strategies for you in this phase would be provide more positive reinforcement. Let them know that you see the change, you're encouraged by it, you're proud of them, etc. Remind them of the positive benefits they're going to see early on. Let them know what's coming just around the corner of this process so that they see when those things do happen, it breeds more confidence, a better relationship that you'll have with them, leaves them looking forward to the next set of changes that they can work toward. And verify their support system. Since most of the patients, most of the actions and changes that they make happen outside of your interaction with them at home in their day-to-day life, verify their support system at home. Maintenance and relapse prevention stage is the person who's, instead of 2 weeks into a diet, now 2 months. Instead of a few weeks into their smoking cessation program, they're now several months down the road. Much different strategy here. Again, encouragement and support is critical. You may, after a patient has achieved a certain amount of time of starting a new diet, you may check off that the patient's goal was met, when in fact there's still that maintenance or chronic upkeep type of approach that you'll need to work on with them. Continue to identify any barriers, new barriers that may come up farther on in the process. Again, take a pause now. Think about patients you see who are in the preparation phase. We give you the example of a hypertensive patient who agrees to try a pill box as a reminder. Think about the types of action patients you see. An example might be a patient with diabetes who has started dieting and now maybe has added insulin to the regimen. And maybe a maintenance type of person, someone again who I mentioned this before, who quit smoking 8 months ago, perhaps has a new stress in their life, either at work or at home, and now the urge and the risk of starting to smoke again is higher. With that as a backdrop, let's talk about the sort of the essential elements, the backbone of motivational interviewing. Motivational interviewing is one approach that can be part of a health behavior change program or approach that you have with your patients. You sometimes see it described or summarized under the REDS acronym, REDS, which is roll with resistance, expressing empathy, developing discrepancy, supporting self-efficacy. Number 2 and 4, as healthcare providers who work with patients all the time, I think, and talking with folks, I think 2 and 4 is something that comes natural to us as healthcare providers, and we tend to be pretty well practiced at and pretty good at to start out with. Number 1 and number 3 are the ones that I think, if more work is needed, it certainly can be in these 2 areas. We'll talk more about these in detail. Just wanted to kind of give you a high-level overview of these 4 elements of motivational interviewing. Rolling with resistance is sort of the first connection or first point of contact you'll have with a patient who might be in that pre-contemplative phase. They're not willing to make change. They're not even interested in talking about it. It might even make them uncomfortable to talk about it. When you hear that kind of resistance or pushback, get some clarification. The second to last bullet there can be key, repeating your understanding. If a person cuts you off when you want to go down a road and talking about a certain topic, they voice a concern right out of the gate, nope, I don't want to talk about smoking right now. I've tried that, it doesn't work. A way to repeat your understanding is sort of to turn that around and just sort of reflect it back to them and say, so you've had some bad experiences quitting in the past. Tell me more about that. Sounds like you're pretty concerned about going through the same thing again, and let them reveal some of the reasons, some of the misconceptions or barriers they've had in the past. The human nature in all of us is when we hear resistance, we want to give them the right answer. Since we're healthcare providers, we're experienced in these areas, we want to tell them right away what the right information is. That's the point. If you can get to that and work on your own habit of not automatically downloading information, but taking a step back and let them reveal a little bit why they're resisting. Because the reason you think they're resisting may not be the reason that's going to get them over that hump. There may be other barriers out there. Example, and I'll throw this out here and we'll phrase it as a poll question. You can pick your answer and we'll show you the actual answers in a moment here. A 50-year-old patient with hypertension says, I just don't like the idea of taking medicine every day. What would be an appropriate motivational interviewing response? One might be, well, if you want to get your blood pressure under control, you need to take the medicine every day. The second response might be, high blood pressure is a chronic illness, and you have to take your medicine every day. Third option, what in particular don't you like about taking your medication every day? And then finally, having to take your medicine every day concerns you? So as you guys ponder that, maybe pause it and think about your response. I will go to the next slide. And the 2 responses that are most consistent with motivational interviewing would be number 3 and 4. What in particular don't you like about taking your medication every day, or having to take your medicine every day concerns you? Either one of those would be fine. My preference is number 3. Number 4 could be a yes or no question if you think about it. Those tend to be less revealing because some patients will take that option and just say yes, and it does concern me, and not give you any more information. Whereas number 3 is bound to lead to a more in-depth conversation about some of the barriers. The second principle, expressing empathy. I think we do that pretty well as healthcare providers, accepting that patient's current stage, their current habit, their current behavior that you're trying to work on, accepting it, not judging, and that's going to be your best environment for facilitating change. Reflective listening is a good fundamental approach here, and we'll give you an example in a moment. Remember that empathy creates the climate for change. That's partly the trust that you develop with your patient, and you should try and maintain that throughout the process. Example, if a patient with hypertension says, I can't believe I have high blood pressure. I have always been so healthy. What would be an appropriate response? So just from the way they phrase their concern, can't believe I have high blood pressure. I've always been so healthy. That might shape how you respond to them. One response might be, this has come as a shock to you, especially since you've been so healthy. Second response, well, even healthy people get high blood pressure. Third option, millions of people have high blood pressure, and it is perfectly treatable. And then the last selection here would be, you're having a hard time accepting you have high blood pressure because you've always been so healthy. If you want a moment to talk about it or think about it, you could pause here. Otherwise, we'll go right on to the answer. And 1 and 4 are probably most consistent. The reason being is both of these reflect what the patient just told you, that it's a shock in the first response, or they're having a hard time in the second response. And it also confirms what they told you in that they feel like they're healthy. Why do they have this high blood pressure diagnosis now? So you're giving that back to them, especially since you've always been so healthy. And it kind of gives them some confirmation that they are healthy. You know they've always been healthy. It's almost some affirmation for them for taking good care of their health. And it also gives that option that this is not an end-of-the-world kind of situation. The diagnosis of high blood pressure can be treated. And, so essentially it addresses number 2 and number 3. Even healthy people get high blood pressure, or millions of people have high blood pressure, without putting them in that category with many people or millions of other people. The third principle is one where it's really worth taking a step back and thinking about, how do we do this in our practice? It's really important. This is sort of the where the rubber meets the road on motivational interviewing. Discrepancy, also called dissonance perhaps, it's pointing out good and bad things about the change. It's creating the disconnect between what the patient currently does and what they want to have happen. By creating this discrepancy, you're kind of creating an uneasiness or a tension for the patient, throws their system out of kilter. And the patient then would be able to start making their own argument through maybe that intrinsic inside motivation for themselves of why they want to make the change. That's a much more powerful approach, and that's much more likely to create sustained change than that dictating, teaching that type of approach. Example here, patient who has a child with severe asthma continues to smoke. Which of these would be the best responses? Number 1, what you're doing is harmful to your child and you need to stop. Number 2, we've talked in the past about the effect your smoking could have on your child's asthma. Tell me what your thoughts are about that. Number 3, cigarette smoke on your clothes can make your child's asthma worse, even if you smoke outside, and you must stop smoking. Or lastly, what are your thoughts about smoking around your family? On a scale of 1 to 10, how important is quitting to you? Maybe on that same scale, how confident are you that you could quit if you tried? Let you guys think about the response you would give, and then go to the slide with the answers. Probably 2 and 4 would be the most consistent responses with motivational interviewing. Let's look at 2 for a second. We've talked in the past about the effect your smoking could have on your child's asthma. You're just stating a simple fact that in the past this conversation has come up and you've had that conversation. Tell me what your thoughts are about that. So you do a couple things there. You confirm what the patient remembers. It's almost a teach-back technique happening. You're confirming what the patient remembers about your previous conversation. And then you're getting them to make the connection. They're verbalizing it, they're thinking it through, it's their own words, it's their own thought process about how their smoking in the house can actually affect their child's asthma. That's dissonance that the patient then has to deal with. They can deal with it in a variety of ways, and I'm sure you're familiar and seen these different ways. But one of them, and a logical one, and one that you would encourage and negotiate towards, would be trying to quit smoking again, another quit attempt. The last response, similar approach, although you assume the patient remembers the information that you assume that the patient remembers the information you'd exchanged around smoking cessation, and you're moving right into what are your thoughts about smoking around your family. So you're getting into that, having the patient verbalize the dissonance, the disconnect. And you're also using some other techniques that might be useful and will come up later in this series, but creating that scale of importance for the patient to verbalize and the scale of confidence. On a scale of 1 to 10, how important is it to you? On a scale of 1 to 10, how confident are you that you could quit? Supporting self-efficacy we won't spend a lot of time on. It's another one of those things I think we do pretty well with as healthcare providers. Just interpersonal communications with making sure the patient sees and understands and hears that you are proud and recognize and acknowledging the positive steps they've made. It gives them the ability that and the confidence that they can do it, and that's an important motivator in and of itself. The one thing I would bring up here and highlight is the second to last bullet, praising behavior, not person. Praising behaviors means the patient, if they were to have a setback, if they were to start smoking again or go from, losing quite a bit of weight and then gaining some of it back, as you praise behaviors, patients know that they can create those behaviors again. It doesn't become so much of a personal or maybe a guilt-associated situation. So if somebody set a quit date and connected with a behavioral modification resource, that can be replicated. The patient's confident that they can do it. You praise that behavior, and it sets up a good environment for setting another quit date in the near future. Example here, during his last visit, a patient with diabetes is told he needs to start exercising as part of his treatment. You have earlier rolled with resistance and empathized with him, and now to support his self-efficacy, what's an appropriate response? 1, what are your thoughts about your exercise program? 2, you really need to do it, not just think about it. 3, getting into a regular exercise routine will help you. Or 4, good, what kind of exercise have you thought about? Think about what responses are most consistent with motivational interviewing. Hopefully, as you continue to work on these skills, they become the responses that you would choose and you would actually use in your practice. The answers are, the best answers would be number 1 and number 4. What are your thoughts? Again, everything is focused on the patient here. What are your thoughts about your exercise program? It's not the exercise program you give them, and it's not, here, I think this is a really great exercise program. We'd like you to try it. Their thoughts, their exercise program. And then the last one, good, that positive reinforcement, one word, good. What kind of exercise have you thought about? So it moves right into the next conversation, which would be, have you been looking at any exercise programs? Have you tried anything? Which would give you the option of assessing what they've been thinking about and whether it's something you're comfortable with. If not, it gives you the option to introduce one, hey, here's an exercise program that other patients of mine have tried and thought has been pretty reasonable. We're just about at the end now, and this is a chat opportunity or an opportunity to think about which of these techniques we've talked about so far would be good ones to apply in your own practice. Think about patients you commonly have challenges with, perhaps, in getting them to change some of their behaviors, commonly seen patients, so some of your more frequent chronic types of conditions that you treat, and some of the easy steps of motivational interviewing that you think would be a good place to either start with or add to what you're currently doing. Example might be just using some of these techniques with non-adherent CHF patients. So getting our patients with CHF who aren't taking their medicines regularly, what are some of the things we can do to focus specifically on that? And then a homework item to consider over the next few weeks would be a 1-1-1 approach. Take one of these techniques use it with at least one patient, one time, and get some confidence and comfort with doing that. Down below, we have given some examples. Moving a pre-contemplative patient to contemplation, which would mean getting them to at least maybe agree that during this visit, later on, or at the next visit, that they would talk about a behavior that you think is important to address. Try reflective listening with a patient, and that's where you take the patient's concern, pushback, statement, turn it around, reflect it back to them, and asking them to tell you more, get more information from them. This is one you could even try at home before you brought it into the practice. Try it with a spouse, a family member, a friend, a child, see what the outcome is. Or using the REDS technique, rolling with resistance, expressing empathy, developing discrepancy, or supporting self-efficacy with any patient that you're asking to set a goal. Thank you for listening to the program, participating, and if there are any evaluations that you'd like to complete, check with your MPro point of contact.
Good afternoon, everyone. Welcome to the WebEx. We'll be just starting here in a few minutes. But before we get started, I just want to go over a few important tips. Please follow the instructions on this screen if you're having any difficulty logging in. Secondly, I want to emphasize that please enter your name, your practice name, and number of participants from your practice in the chat window on the right. If you're unable to see the chat window, as you can see on the screen, you can go to View on the top, and then Panels, Manage Panels, and click on Chat. And in order to add the chat window, you click on Chat and then click on the arrow to move it to the right, so you're able to see the chat window on the right. Please feel free to use the chat function. If you have any questions during the presentation, we will also be having a few minutes question and answer session at the end of the presentation, and we'll be more than happy to address any questions that you may have after the presentation through email, as you all have my contact information, and we'll be able to address any questions later on as well. We're going to go ahead and get started. I'm going to mute everyone's phone lines, and we'll reopen the phone lines at the end of the call. I want to thank all of you for joining us this afternoon. I want to take a moment to introduce myself. I'm Mandy Kaur, one of the Clinical Applications Coordinator at MPro. I completed my Bachelor's in Business Administration and Information Systems Management from Wayne State University in Detroit. I recently finished my Master's in Public Administration with concentration in Healthcare Administration from Oakland University. I'm working with MCEDA and also the lead on the Prevention Learning and Action Network. Our other speaker for this afternoon is Kevin Townsend. Kevin is a medical outcomes specialist with Pfizer, where he's involved in provider education and outcomes research activities. He completed pharmacy school at the University of Michigan and a pharmacy residency at Duke University Medical Center. Kevin's professional and research interests are in the areas of patient-centered medical home, cardiovascular disease, and medication adherence. Allow me to introduce the MPro organization. MPro serves as the federally designated quality improvement organization for Michigan under contract with the U.S. Centers for Medicare and Medicaid Services. The work we do under this contract is called a scope of work, and it lasts for over a 3-year period of time. Currently, we are in the 10th scope of work, which runs from August 2011 to July 2014. In addition to the physician and hospital settings, MPro also performs independent dispute resolution, external quality review, and lastly, we have a beneficiary protection division. One aspect of the current scope of work involves the Prevention Learning and Action Network initiative. We call it the Prevention LAN, and that is why you all are here today. The call today is based on improving patient adherence through health behavior change. I will be talking about the next few slides, and then Kevin will take over with the rest of the presentation. Kevin's presentation material is developed by Pfizer. The focus of the LAN initiative is on patient and family engagement, clinical decision support and quality improvement, physician quality reporting system and meaningful use, and to foster a community of collaboration and identifying best practices, interventions, and tools. What are we trying to achieve? We are trying to achieve better patient outcomes and improve quality of care. There are different definitions of quality in care, and according to Institute of Medicine, quality of care is the degree to which health services for individuals and populations increase the likelihood of desired health outcomes. So how do we get there? How do we achieve quality? Quality is definitely an ongoing process. It's a continuous process. According to Mosby's Medical Dictionary, the definition of continuous quality improvement is a system that seeks to improve the provision of services with an emphasis on future. The improvement is ongoing. One important aspect in achieving better outcomes is the improvement of patient adherence. Why is patient adherence important? The patient must follow the recommended regimen. Improved healthcare outcomes largely depend upon a patient's adherence to recommended treatment. According to the National Institute of Health, in some chronic disease conditions such as cancer, diabetes, cardiovascular diseases, more than 40% of patients sustain significant risks by misunderstanding, forgetting, or ignoring advice. So how do we address patient adherence? Through acceptance and understanding. This is a mutual relationship between providers and patients, and it's based upon patients' knowledge and understanding of the condition as well as the treatment. The clear and thorough communication between providers and patients, and also the trust in the therapeutic relationship. Knowing the patient, not just as a patient, but then knowing the patient as a person is the key here, which includes knowing their beliefs, attitudes, and cultural context, and social supports and emotional health. Why is it important to engage our patients? And I love the definition by NCC, National Coordinating Center. I think it's a very well put together. Knowledge is power. An engaged patient is an empowered patient, more likely to adhere and follow instructions because they own it. So how do we engage patients? There are many ways, and for those patients who prefer technology, there are several apps on smartphones like automatic patient reminders or apps that provide health-related feedback. Centers for Disease Control, CDC, and CRUST also has links, and we will be more than happy to provide you these additional tools and resources. According to the survey done by MedTech Media, the majority of patients surveyed are more likely to use an interactive app that can analyze logged information and provide feedback. Ease of navigation was the top feature. Most were interested in using a health app to gain information. On this slide, we have included some interactive patient tools for provider use, such as interactive adult scheduler for immunizations, and the link on here. I'm just going to go ahead and click on this link. And if you scroll down to the adult immunization schedule, I'm going to go ahead and click on that, and you will see in the middle of the screen here, there's a poster here. So here you will find posters, interactive schedulers, and even a smartphone apps available for your patients. On this slide, you'll see additional patient education materials such as patient engagement, which are disease-specific, so it's condition-specific educational materials. And if I go ahead and click on this last third link here on this slide, and you'll see, as it says, topic condition-specific. So all those education resources are on this site, and you'll find for educating and engaging both the patient as well as the patient's caregivers. It is well-known fact that caregivers and family members can play a vital role in the success of a patient's treatment plan. And please be sure to visit EMPRO's website section devoted to the 10th scope of work to improve health for populations and communities initiative overview. And we're going to go ahead and click on the link for EMPRO. And as you can see here, we are trying to focus on these prevention measures. The breast cancer screening, colorectal cancer screening, influenza immunizations, pneumococcal immunizations, and improving cardiac health. And next time, please join us for more information on the Governor's Award of Excellence. We all know how much you love Governor's Award, and also to learn about the opportunity for CME hours. I do also want to mention that at the end of the presentation, there is a link, a survey link, and please do complete that survey evaluation. We do take our evaluations very seriously, and we have scheduled all these education sessions during the afternoon session between 12 and 1. But if you would prefer a different timing that works for you better and more convenient, please do let us know. Please do state that on our evaluation. And here is our contact information, my contact information, as well as Daniel's contact information. We both, Daniel and myself, are the leads on the Prevention Learning and Action Network. And if you have any questions or you would like more tools and resources, we'll be more than happy to provide that information to you. You can contact myself or contact Daniel. And now I'm going to go ahead and